Is it on? This light's on. Oh, hey there, class! We're reporting live from the microbiology lab. Today we're going to discuss the new ACL reconstruction.
Brace yourself. You're about to experience a miracle.
So sit back, relax, and enjoy the show. And please no sleeping. That means you, Adam.
Welcome to Regal Entertainment. Refreshments are available in the lobby. And please, keep our theater clean by disposing of trash in specified containers. And remember, gift certificates are available for any special occasion. Enjoy the show.
The science guy. Bill Nye the science guy.
Science rules.
Bill Nye the science guy.
Inertia is a property of matter.
I believe in miracles. Where from? You sexy thing, you.
The anterior cruciate ligament is the primary stabilizing ligament of the knee. It resists anterior tibial translation and rotational loads. It originates at the medial and anterior aspect of the tibial plateau and runs superiorly, laterally, and posteriorly towards its insertion on the lateral femoral condyle.
ACL ruptures. In the United States, more than 200,000 ACL reconstruction cases are reported each year. Individuals who participate in high-impact sports such as soccer, basketball, football, tennis, and skiing are at a higher risk of rupturing the ligament. Although most injuries are sustained during non-contact situation, the ligament ruptures due to twisting or pivoting of the tibiofemoral joint. Symptoms of ACL tears include knee swelling, lateral bruising, instability, and pain.
Currently, there are 3 existing procedures for ACL reconstruction. The first method involves extracting tissue from a cadaver. Tissue is commonly used from the hamstrings, Achilles tendons, or patellar tendon. The other 2 procedures involve extracting tissue from the patient's own body. The bone patellar tendon bone graft uses the center third of the patellar tendon, while the semitendinosus and gracilis graft is constructed from an accessory hamstring tendon. So I'm here in the AT room with Mike Weil today. Mike, how's it going?
Doing well yourself?
Great, thanks. I just have a few questions. So research has shown that ACL injuries are pretty common for athletes. Do you see a lot of them here?
It varies year by year. Tests overall, we average probably 2 to 3 ACL tears to patients that have experienced ACL ruptures per year. It's like the rehab process. But there's a lot of factors that go into what's going to cause an ACL injury from year to year. And so it kind of varies in our patient population.
Okay, so what kind of sports would you say that you see the most of these injuries from?
Our sports do involve a lot more cutting, as well as, so within that, our sports tend to see in our particular patient population, basketball, soccer can be very popular, as well as tennis. Within that, our typical running or linear sagittal plane tend to have a less of a chance for that.
Okay. How long would you say the recovery process normally takes?
It's a subjective question because it depends on your patient. But as a general rule, as far as return to play, we look at a 4 to 6 month range.
4 to 6 months?
However, it really depends on the individual, how they heal, their surgery we use for them, as well as just their strength background coming in. However, at the same time, I would say it really isn't until they get over a year, it's 18 months, to where I would say they're completely fully back, because they still have some strength deficits that are adjusting to their new normal.
Okay. Sounds good. Do patients usually need crutches following surgery?
Crutches help with the ambiating around, and so patients can get around a little bit easier, especially on a college campus. It depends on the actual patient and how much they'll actually need them, as well as the type of surgery that they have and which surgeon completed that surgery.
Okay. How severe is the scarring typically after surgery?
Cosmetically, depending on the type of surgery. So a patellar tendon graft tends to have a larger scar cosmetically, and compared to a hamstring graft, there's a little bit less of a scar formation as far as the cosmetic goes. So there's a significant cosmetic defect there. However, through some different manual therapies that we can use with instrument-assisted soft tissue mobilization, we can help to minimize the scarring internally to where all the skin is pliable and the tissues are pliable and mobilized again. So cosmetically there's a deficit, but normally we can get that to where functionally it does not affect that patient.
Okay. Well, thank you for your time. That's all for our sports update. Back over to you, Leah.
Very insightful. It's currently 68 degrees and there's a 30% chance that it's already raining. Traffic here is moving pretty smoothly, as you can see, and oh my, what do we have here? Hi, what's your name? What happened to you?
My name's Andrea. I just had ACL surgery.
ACL surgery, wow. And how does that make you feel?
Sad and upset.
Sad and upset, huh? Well, what's your pain level currently?
8 out of 10, I would say.
8 out of 10, wow. How does that make you feel?
Angry and upset.
Angry and upset, huh? There's a common trend here. How much longer do you think this process is going to take?
Well, for me to go back to full strength, 6 months.
6 months. 6 months. Well, folks, there you have it. ACL surgery is no bueno. That's all for now. Taylor, over to you.
Welcome back, friends. That was very insightful, wasn't it? So now that we got that junk out of the way, let's discuss an innovation that will change the face of ACL reconstruction. Hey, Adam, remember, no sleeping.
Here's what we're thinking. Research has shown that the most positive results were demonstrated by patients who had undergone a procedure involving an autograft, their own tissue. However, regrowing the actual ruptured ligament may minimize trauma to the injured knee and decrease the recovery time, which is why we are including the concept of a bridge-enhanced ACL repair. Additionally, in our research, we found that dogs undergo ACL reconstruction too. There are 6 existing procedures of dog ACL repair, so we looked further into the method that is most effective for larger, heavier dog breeds. Considering that large dogs may weigh up to 200 pounds, we decided that this method may be effective on human beings, so we designed a combination hybrid method of ACL repair.
Bridge-enhanced ACL repair is a game-changing new procedure that stimulates a torn ACL to heal itself, eliminating the need for a tendon graft. First, the surgeon places sutures to stabilize the ACL and the knee. A sponge made of special proteins is placed into the gap between the ends of the ACL, providing a bridge for the ligament to grow into. After the bridge is in place, blood is drawn from the patient. This is added to the sponge, creating an environment for a clot to form, jump-starting the healing process. The surgeon then uses the sutures to pull the torn ends of the ACL into the sponge. Over the next 6 to 8 weeks, the ends of the torn ACL grow into the sponge. They reconnect, and the healing tissue replaces the sponge.
The material choices that we used for our design was a sponge that was made of silk collagen. It was knitted silk scaffold combined with collagen matrix. It better mechanical properties, more native microstructure, and a larger diameter collagen fibrils compared to silk scaffolding alone. In Shen et al., advanced ACL repair and regeneration was seen. It protected articular cartilage and meniscus from degeneration and suppressed osteoarthritis occurrence in short and long-term outcomes, and it created a conductive healing environment. Our second material choice was sutures, which was made of visceral rapidae, also known as polyglycic 910. It was a synthetic, absorbable, sterile surgical suture. It was composed of a copolymer, so 90% glycide and 10% lactide. It was a braided suture woven like a string that was absorbed in 2 weeks.
The traditional repair method of dog ACL reconstruction is an extracapsular technique that uses a strong leader-line suture material to provide joint stability. As you can see, this procedure involves drilling minuscule channels, about 1 millimeter in diameter, through the lateral femoral head and the anterior medial tibial plateau. The bone will regenerate to close the tunnels as the sutures are absorbed. The suture's purpose is to prevent unwanted movement of the joint through the duration of recovery. It's not meant to stay in place for the dog's entire life. Normally, this procedure involves replacing the ruptured ligament with a virtually indestructible material called fiber tape. However, we've eliminated this aspect through the implementation of the bare technique. Our material choices are all polymers. Therefore, they all exhibit considerable strength, flexibility, and ductility. The silk, a component of the silk collagen sponge, demonstrates impressive mechanical strength, environmental stability, controlled proteolytic biodegradability, morphologic flexibility, and ability for amino acid side change modification to immobilize growth factors. The collagen, also a component of this chosen sponge material, exhibits high tensile strength due to its composition of 3 types of polypeptide chains. It also exhibits thermostability and ability to bond and interact with other molecules. The designated suture material, polyglactin 910, is absorbable through hydrolyzation, synthetic, and exhibits poor external wound healing. Additionally, none of our materials were coated.
Because these materials are FDA approved, research has indicated that they exhibit minimal toxicity that does not present severe risks. To eliminate microbial bacteria, the material was first cleaned before undergoing plasma sterilization. Plasma sterilization uses radiofrequency gas plasma. This hydrogen peroxide gas is excited by radiofrequency discharge in a vacuum with UV radiation. This procedure is performed at temperatures less than 50 degrees Celsius and does not involve toxic chemicals. Sterilization is quick and is performed in 1 minute or less. However, porosity presents a problem in woven material, such as our scaffolded sponge and braided suture. Additionally, the sponge is designed to have a diameter of less than 6 millimeters because it fits tightly to the ACL, which has an average diameter of 3.5 millimeters.
Both of our materials demonstrated satisfactory biocompatibility. The silk collagen sponge did not facilitate encapsulation, but did demonstrate high interaction and bonding with tissues. During degradation, the visceral rapidae sutures produced non-harmful, non-toxic compounds. The material's degradation occurred due to products excreted by the kidney or eliminated as carbon dioxide and water via biochemical pathways, which was used in drug encapsulation and delivery application.
We performed further research using in vitro testing to confirm our assumption that the silk collagen sponge would facilitate the most growth.
Hello friends, today we are reporting live from Damon College's Building 110 second floor lounge, and we're going to culture some sponges. So here we have our first sponge, which is your average dish sponge. This one is the collagen sponge. This one is the silk sponge, and this is a silk collagen sponge. So we're gonna inject them with some blood from our patient. And it's day 15. Let's see what happened to our sponges. So this is our dish sponge, and whoa, not what we wanted. Nope. All right. Then we have our silk sponge here, and I don't really see much. This collagen sponge here, if you get close, you can see a little bit of red not what we'd like. And then our silk collagen sponge here, wow, exactly what we wanted to see. I would say that's a good one.
Culturing the silk collagen sponge produced satisfactory results when in contact with the patient's body. There were no observable signs of toxicity produced when the sponge was injected with human blood, and no harmful byproducts were detected when the sponge was absorbed. Determining that this material is compatible with living tissue allowed us to move forward to in vivo testing. First, this product was tested on dogs because dogs undergo ACL reconstruction similar to humans. This testing involved dogs with torn ACL ligaments. Informed consent was obtained through the dog owner. Following the procedure, the dog's activity levels were strictly monitored. During week 1, the dogs were limited in their activity. Weeks 2 through 4 included follow-up appointments every other day. Weeks 5 through 8 consisted of weekly checkups, and monthly checkups were performed from weeks 9 through the remainder of the first year. Significant improvements in strength, range of motion, and laxity were recorded during each checkup, and results indicated that the material was successfully integrated into the dog's bodies and produced no adverse effects.
I feel good. I knew that I wouldn't. I feel good. I knew that I wouldn't. So good, so good. I got you. Wow!
Potential issues and risks that presented when we did our testing on dogs was that they may not accurately depict effects of the surgery on humans because the anatomy is not identical. And there is a 30 to 50% chance of ligament ruptures bilaterally, and they have a much shorter lifespan than humans. As with any surgeries, risks include but are not limited to pain, nausea, infection at incision site, which can worsen scarring and require additional surgery. Also numbness, tingling, and the braiding sutures polygalactic 910 are more susceptible to inflammation.
This new and improved method provides numerous benefits. First, the surgery is performed by administering a femoral nerve block without the addition of anesthesia. Eliminating the need for anesthesia decreases the cost of the procedure as well as eliminates various associated risks, including pneumonia, blood clotting, aspiration, malignant hyperthermia, and blindness. Additionally, the procedure eliminates the need for crutches postoperatively. By eliminating the need for crutches, we will avoid the dependence on crutches that many patients may develop. We hope this will improve immediate postoperative functional ability. Additionally, in many cases, patients form bad habits when using crutches, such as slouching, which may compress the radial nerve, causing long-term nerve damage. Therefore, without crutches, these issues may be avoided altogether. Also, encouraging patients to use the surgical leg almost immediately following the procedure will eliminate the risk of muscle atrophy. Furthermore, the procedure results in minimal scarring compared to alternative methods. This will result in increased cosmetic appeal as well as less tissue damage.
FDA issues are as follows. Pre-market issues were not of great concern. Fortunately, all of our materials have been considered safe, non-toxic, and biocompatible by regulatory agencies in virtually all developed countries. Additionally, they have been approved by the FDA, so we were able to quickly get this idea to market and create our patent. Additional applications of these materials can be brought to market sooner and are cost-effective. Post-market surveillance included the collection of long-term results from clinical trials. We contacted patients on a monthly basis for 10 years. Both the sutures and the sponge should deteriorate within a short period of time following the procedure, so ideally no residual materials should remain. Additionally, we kept a close eye on re-rupture rates and found that 0% of patients experienced re-ruptures.
For our clinical trials, we selected subjects based on different inclusion and exclusion criteria. The inclusion criteria included college athletes with ACL tears, 50 of them being males and 50 of them being females. The exclusion criteria was meniscus tears, previous knee surgeries, and osteoarthritis. In our study design in weeks 1 through 8, we measured progress on a weekly basis using the IKDC forms, the Lockman test, the pivot shift test, and a range of motion test. From weeks 9 to 1 year, we had monthly follow-up appointments, and from 1 year to 6 years, we did 6-month follow-up appointments. Informed consent was obtained prior to patient participation and data collection by using documentation with signatures that explain potential risks and benefits with a witness present. Our study design was based on current ACL studies.
We interrupt our program to bring you this important message.
Hey there, I just had the new mirACL ACL reconstruction. Check it out.
You look good. How do you feel?
Even better.
I feel good. I knew that I would not. I feel good. I knew that I would not. So good. So good. I got you. I feel nice.
Out of the way, Gimp.
Oh no, not stairs.
Loser.
Oh, there, it's okay. Here's a sponge for your tears. $598, $599, $600. Oh, feeling great.
I believe in miracles.
Please note that the information contained on this HealthBridges info website is general information only and not intended to constitute medical or mental health treatment or advice. If you have questions, you should contact your medical and/or mental health provider about your specific situation. This website contains links to other websites and resources. We take no responsibility for the content of other sources, electronic or written.
Sex thing, you. I believe in miracles. Since you came along, you sex thing.
What happened to you?
ACL tear.
What the word?
This program was made possible by the Corporation for Public Broadcasting and by contributions to your PBS station from viewers like you. Thank you.